Now let's see what do we have for our deep venous thrombosis case study. We have a 58-year-old man who has had bad swelling in his left foot and ankle and pain in his left calf for 6 days. The pain has been getting worse for the past 24 hours. Past medical history, he had previous episode of DVT at the age of 54, and also he has type 2 diabetes mellitus for 5 years now. A preliminary diagnosis of DVT is made. Why? Past history, predisposed patient, obvious clinical picture, pain and swelling in the lower limb. And the patient is admitted to the hospital for a thorough clinical workup. The vital signs, blood pressure kind of average, normal, pulse 110, respiratory rate 16, temperature a little bit elevated, height and weight and oxygen saturation 98%. Doppler ultrasound showed left lower extremity showed no flow to the left posterior tibial vein. No flow of the left posterior tibial vein. Venous obstruction, venous thrombosis, deep venous thrombosis. Question: which vital signs are abnormal and why these are consistent with the diagnosis of DVT? Now, tachycardia, we have kind of low-grade temperature, kind of low-grade fever. Both are signs of inflammation, kind of thrombophlebitis, which usually associates deep venous thrombosis. What are the risk factors of DVT? From the lab data. From the lab data, we can see elevated serum homocysteine concentration. Elevated serum homocysteine concentration puts the patient at a higher risk for developing thrombi and protein C deficiency. Both of these conditions are risk factors for thrombophilias. What's philia? Philia, to love. Philosophy is love the truth. Philosophy, love the truth. So thrombophilia, you love making thrombi. When are you going to love making thrombi? When you have elevated serum homocysteine or when you have protein C deficiency, and this patient has the two conditions. Identify two other abnormal lab findings consistent with the diagnosis of DVT. The other two abnormal findings are elevated white blood cell count and increased ESR. Both are non-specific findings associated with the development of a thrombus and inflammation. Prior to warfarin therapy, list two drugs that may serve as initial treatment for this patient. We know that this patient is going to be put on warfarin for his DVT, but what can you use initially? The initial treatment is going to be heparin or enoxaparin. Heparin or enoxaparin. By heparin, I mean the unfractionated heparin. We do not use it commonly nowadays. We better use enoxaparin, the low molecular weight heparin. Okay, so for how long should this patient be treated with warfarin? This is an important decision to be made in managing such patients. So look at the patient's history carefully. Since hypercoagulability is due to a protein C deficiency, which is a major contributing factor to the patient's deep venous thrombosis, anticoagulation is indicated for life. Anticoagulation for life with low dose warfarin, and this would be the appropriate preventive measure. The second case study here is a case study about pulmonary thromboembolism. And the key features: we have a 30-year-old woman presenting to the ER following 90 minutes of chest pain. The pain is sharp and constant, and it is right-sided to the right side, and also right-sided mid-back pain that becomes worse on lying down or taking a deep breath. Very important thing to note in the history. The pain is related to taking breath. Pain on taking breath, this is not cardiac, this is pleuritic type of pain. And she also has had difficulty breathing. Past medical history, positive for protein S deficiency, another thrombophilic risk factor. Social history, 12-pack year smoking history. Now, her vital signs showed a little bit of tachycardia, pulse 105, blood pressure average, respiratory rate 40, tachypnea and labored breathing, tachypnea, tachycardia, chest pain, pleuritic chest pain. We should think of pulmonary embolism. Lower extremity venous duplex findings consistent with bilateral DVT. Here we have a positive duplex and we have suggestive symptoms in a predisposed patients. What more do you need to diagnose pulmonary embolism? Nothing, and you can start treatment right away. So what clinical manifestations suggest pulmonary thromboembolism in this patient? Of course, the sudden onset of persistent chest pain that intensifies with deep breathing and the breathlessness. Identify 5 risk factors of pulmonary embolism in this patient. Recent long airplane trip that was in the patient's history. Chronic protein S deficiency, which is another risk factor for thrombophilia, for forming thrombi, history of DVT in the lower extremity, use of oral contraceptives, estrogen-containing contraceptives, combined hormonal contraceptives, estrogen and progesterone in one contraceptive pill. Estrogen will predispose to venous thrombosis. Estrogen will predispose to forming thrombi. And smoking. So this patient has 5 risk factors, 5 major risk factors for the development of pulmonary embolism, and the combination of oral contraceptive use and smoking is a very potent risk factor for DVT and pulmonary embolism. Are any of the patient's vital signs consistent with pulmonary embolism? Let's see. Rapid heart rate, yes. Rapid respiratory rate, yes. Both of them consistent with pulmonary thromboembolism. Don't forget, if you have normal heart rate, it's very highly unlikely to be pulmonary embolism. However, these clinical signs, yes, they are non-specific, but they are highly suggestive of pulmonary embolism. You can have tachycardia and tachypnea in other conditions. You can have tachycardia and tachypnea in pneumonia, for example. So you can have tachycardia and tachypnea in heart failure, for example. So you need to do further investigations, but they are highly suggestive. If you have low heart rate or normal heart rate, you cannot think of pulmonary embolism. If the clinician had observed significant jugular venous distension, what is a reasonable explanation? What can elevate the jugular venous pressure in a pulmonary embolism case? This could have been due to sign of right heart failure. So, and this will tell you that this pulmonary embolism has progressed to pulmonary hypertension, and you have right heart failure, and that's why you have elevated jugular venous pressure. And peripheral edema, hepatomegaly are also signs that are typical of right-sided heart failure that complicates big pulmonary emboli. Chest X-ray, what do you expect it to reveal? Based on the patient's clinical findings, it is possible that the chest X-ray may show an area of infarction due to this pulmonary embolism. It might also show dilatation of the pulmonary vessels if you have pulmonary hypertension, or collapse of a part of the lung, atelectasis, the commonest X-ray finding. No, the commonest X-ray finding, as a matter of fact, is nothing. Normal X-ray. But if you have abnormality, most probably it's going to be atelectasis. And you can find elevated diaphragm, pleural effusion, and fluid in the pleural cavity. Which single clinical finding provides the strongest evidence for pulmonary embolism? If you just want to pick one clinical finding, it's going to be what? It is the most accurate test. The most accurate test is positive pulmonary angiogram. But don't forget, it carries a mortality rate of 0.5%, 0.5% mortality rate, which could be too much for you. What might the patient's chest X-ray reveal? I think I answered that before. But here is a good chance to emphasize that the chest X-ray, the commonest finding is normal chest X-ray. Okay, which is a more appropriate duration of treatment with warfarin in this particular patient? Are you going to put her on warfarin for 3 months, 6 months, or long-term anticoagulation? What do you think? The patient has a history of DVT already, and she has chronic protein S deficiency. Therefore, long-term anticoagulation with warfarin is the most appropriate treatment approach. Do you think the use of thrombolytic agent in this particular patient is advisable? What do you think? The patient is stable hemodynamically, no hypotension, no extreme tachycardia, so the blood pressure is normal. And the EKG, normal, no signs of right-sided strain. Therefore, the use of thrombolytics is not indicated in this patient. What would you suspect that this patient's plasma D-dimer concentration is negative? Would you suspect it negative or elevated? D-dimers. Now, you have a pulmonary embolism condition case. What do you think the D-dimer will be? The D-dimer will be elevated, Does it tell you anything? No, because it's not a very positive, it's not a very specific test. It does not tell you much when it is positive, but it tells you a lot when it is negative. If it was negative, you can exclude pulmonary embolism. So here, because the patient has pulmonary embolism, most probably her D-dimer is going to be elevated, and the D-dimer is a degradation product of the freshly formed fibrin clot, and a level less than 500 nanograms provides strong evidence against thrombosis. If you have low D-dimer, less than 500 nanograms, it is not pulmonary embolism. But if you have a D-dimer more than 500 nanograms, it is still not diagnostic, and the patient still needs to be best diagnosed with a spiral CT or any other diagnostic procedures for pulmonary embolism. Okay, in terms of thrombus development, what is the fundamental difference between heparin and alteplase? Both of them can be given in the context of a thrombus. What is the difference between their effect? Heparin and alteplase. Heparin is anticoagulant, alteplase is thrombolytic. So as the name implies, heparin anticoagulant. What does it do? It prevents thrombi from getting larger or from propagating, while alteplase is a thrombolytic. It breaks up or lyses the intravascular blood clots. So if the thrombus is still forming, you give heparin. And already formed thrombus, you give thrombolytics.